My name is Dr. Kamil Vallabh. I'm an emergency medicine consultant and the head of department at Sheikh Khalifa Medical City in Ajman. Thank you once again to the organizers for the opportunity to talk to you today about the ideal STEMI transfer protocol. So when I think about the ideal STEMI transfer protocol, I try to view it in the context of a system of care. And developing a system of care is paramount to all successful transfer protocols. When I think about the system of care, especially in terms of cardiovascular care, it's about the patient, EMS, the emergency department, the PCI referral center, and the PCI capable center. And all these elements need to be optimized and work together in a coordinated fashion to ensure that the patient gets to reperfusion as quickly as possible. So optimal patient outcomes can really be achieved by strengthening and optimize every single element in the context of this system of STEMI care. So this is where I currently work, the emergency department at SKMCA. So SKMCA is a medium-sized hospital with a total of 162 beds, and this includes 24 critical care beds. It's the only semi-governmental hospital in the Emirate of Ajman, and we serve a catchment area of approximately more than 500,000 people. So SKMCA manages a significant burden of both acute and chronic cardiovascular disease and patients with a large volume of acute coronary syndromes requiring either referral for primary PCI, urgent PCI, or admission to our HDU. I want you to note the facility-based ambulances to the right of your screen, and this is a critical component of the ideal transfer protocol, which I'll expand on a bit later. Unfortunately, we don't have interventional cardiology services based at our facility, and we need to refer our STEMI patients for primary PCI to another facility called Sheikh Khalifa Specialty Hospital, and this is based in the Emirate of Ras Al Khaimah. It's located about 55 kilometers away, and the travel time to SKSH is approximately between 35 to 40 minutes. So in preparation for the talk, I considered three scenarios. Ideally, a patient would present directly with EMS or as a walk-in to a PCI-capable center. This is the most attractive strategy to reduce door-to-balloon times. But there are barriers to this, though. Unfortunately, in our setting, there's fragmented EMS systems, there's laws prohibiting EMS bypassing certain hospitals, and there's also laws pertaining to crossing Emirates. So often, patients come to a facility, and that facility has to refer a patient onwards for primary PCI. The second scenario would be a patient presenting to a facility where geographically, based on the location and other factors, primary PCI may not be achievable within 120 minutes. In this case, a drip and ship strategy is employed, where the patient receives fibrinolytics, and then the patient is then transferred to a center capable of PCI. The third scenario, and the focus of my talk today, is a patient presenting to a facility that needs to refer a patient on for primary PCI, and a scenario in which we can meet the target of 120 minutes. So as mentioned earlier, the ideal transfer encompasses many elements, but what we want to do is ensure that the patient reaches the cath lab in a safe manner and ensure quality of care throughout the continuum with a good outcome, obviously, for the patient. The elements include pre-transfer logistics and optimization, patient factors, your transfer team and the ambulance, transfer medication and kit, as well as the PCI capable center. So let's talk about the pre-transfer logistics and optimization. So at SKMCA about 2 years ago, we embarked on a process improvement initiative to re-engineer our very convoluted and complicated referral process and pathway. Prior to this re-engineering, our process involved multiple steps. It was very decentralized in terms of requiring to contact many different people to get the patient moving. And this contributed to a lot of wasted time. So we focused on improving this process by making it very centralized in terms of decision-making, where the ED physician is completely responsible for the decision-making. We established a very good referral pathway with our PCI capable center. And this involved establishing a single hotline number, some backup numbers, a very safe platform to communicate details like ECG and clinical info. We protocolized the immediate treatment in terms of aspirin, clopidogrel, ticagrelor, and heparin that the patient required prior to transfer. And we ensured also that there was an unconditional acceptance of all STEMI patients, despite financial status and bed availability. And we also optimized our consent process and conducted many mock STEMI drills to identify potential opportunities for improvement, as well as obstacles that we needed to work on. And ultimately, what we got to was a very simple and linear STEMI referral process. And we created a target to get the patient out of our ED within 40 minutes. And this, coupled with a travel time to our PCI capable center of 40 minutes, would ensure that our patients safely met the target of 120 minutes for door to balloon. Just to note that our transfer ambulances are facility-based, and that makes a very big difference. You know, the old quality adage that you cannot improve what you cannot measure holds so true for our STEMI referral process. And we deconstructed the entire referral process into many micro processes. And we constantly evaluating these steps to look at opportunities where we can shave off some time. So if you look at the slide from the left, when the patient presents to the emergency department, we track things like time to ECG, time from ECG to diagnosis, time from diagnosis to referral initiation. We actually track the ambulance in terms of calling ambulance, time the ambulance arrives on deck in the ED, as well as our travel time to Russellheimer. So our target is to get the patient out of the door within 40 minutes. And obviously our target in terms of door to balloon is 120 minutes. What really made a difference for us was an in-house STEMI alert. And this is essentially a process when a STEMI or STEMI equivalent is identified that triggers multiple people, paperwork, and processes to start running in a very parallel manner to try and optimize the patient before the patient leaves. The emergency physician would get a hold of the interventional cardiologist on the hotline. The ECG would then be transmitted, and then protocolized treatment would be given at the same time. The ambulance is mobilized and the patient is loaded, and we try to get the patient out as quickly as possible. I often liken this process to Formula One pit stop because it's a classic example of parallel processing and how important this is to ensure that multiple tasks can be completed as timelessly as possible. So the other element we need to consider are patient factors. And obviously, the sicker the STEMI patient is, the more resources and time they will consume before we get them out of the door. So the goal will always be to get the patient out as quickly as possible, but the clinical condition of the patient may dictate otherwise. Patient may require resuscitation and may require the initiation of vasopressors, inotropes, ventilatory support in the form of non-invasive ventilation, or intubation may be required before transfer. Patients may require transcutaneous pacing, and sometimes patients post-cardiac arrest with a STEMI, obviously require post-cardiac arrest management. So these are all things you need to factor in terms of your transfer time. Obviously, the goal would be to try and get the patient out as quickly as possible, but maintaining patient safety and stability is key. The next thing to consider is the transfer team and the ambulance. And as mentioned previously, what has made a really big difference for us is the fact that our ambulances are all facility-based, and we don't depend on any external agencies like EMS to transfer the patient on in terms of inter-facility transfers. The transfer team must have the appropriate knowledge and skills and the competencies to transfer patients. And ideally, you want this team to comprise of both a physician and a nurse. And how we do it at SKMCA is that both our transfer physician and nurse are ED based. So 24/7, there's availability for transfer team because it's the ED nurse and the ED physician that jump on the back of an ambulance to transfer the patients. It's important to continuously educate your transfer team with regards to predicting and planning for complications and how to respond to them. For example, anterior STEMIs are very prone to electrical instability. So if your team can anticipate these complications, they can prepare and manage accordingly. Similarly, patients with inferior STEMIs are prone to heart blocks, and your team should be well versed on setting up pacing if it's required en route to the PCI center. With regards to transfer medication and kit, our kit includes the standard emergency medication, including adrenaline. We often carry fibrinolytics on board with us should a patient decompensate or go into cardiac arrest and be a situation where you might need to consider en route fibrinolytic therapy. Medication for procedural sedation and analgesia. This is basically to cater for patients that may develop arrhythmias that may require cardioversion. Obviously, monitoring is a must on board the ambulance. For patients that are post out of hospital cardiac arrest or in cardiogenic shock, we often send a mechanical CPR device together with the patient should CPR be required during the transfer. The last thing is a point of care ultrasound machine. And it's not what we routinely put on the back of an ambulance, but if you do have that available, I think it would be very useful to carry that device in terms of diagnostics en route. The final thing is the PCI capable center. And this must be an established service. They should be aware that the patient is coming and essentially offer a concierge service with a routine to accept patients by bypassing the emergency department directly and transferring these patients expeditiously to the cath lab. So to sum up, the ideal STEMI transfer protocol is really resource dependent, and its success is interdependent on so many different elements. We need to look at optimizing pre-transfer logistics. We need to consider patient factors that may contribute to delays. Your transfer team and ambulance must have the appropriate skills and competencies. The ambulance should ideally be facility-based. Ensure that all the appropriate transfer medication and kit is available, and have established routines at your PCI-capable center to bypass the emergency department and take the patient straight up to the cath lab. Thank you very much.